This is Blood and Cancer, the official podcast of MDedge Hematology-Oncology. I am the voice of MDedge Podcasts, Nick Andrews. And I'm joined this week, as I always am, by the editor-in-chief of MDedge Hematology-Oncology, Dr. David Henry, who is still basking in the glow of young love. I heard the wedding went well.
Oh, it was really wonderful. My daughter got married this past week, and what a marathon. I couldn't imagine what my wife and daughter have been going through these many months to get it set up. So many moving parts, and they all worked. A couple of ice-breaking little snafus ceremony that actually helped. So we're still basking in the glow, is correct.
Oh, that's so wonderful to hear. And I am in San Diego myself. I'm poolside at a friend's pool, and I'm out here to get some interviews for our sister show, Post Call Podcast, and just to enjoy a little vacation time. And man, there's nothing like waking up every day and not having to check the weather because you know it's going to be sunny and 75.
Oh, San Diego's beautiful. Yeah, enjoy it.
It is amazing. So coming up later on Blood and Cancer, we are going to talk about this week in oncology, which is what is the optimal duration of maintenance in myeloma treatment and multiple myeloma. We'll get into that in a little bit, but I want to talk about what this episode is all about, which is part 3 of our 3-part series for difficult conversations that trainees need to have, and young attendings and even old attendings. I'm sure there's a lot of nostalgia in these conversations. So part 3, Dr. Henry, is how to respond when a patient asks you, what would you do if this was your family member?
So I try not to, I get that question probably once every other week, and I try not to roll my eyes because I really hate that question. What it does is you've just had a nice discussion with the family and the patient, and you're starting to make recommendations. And then they say, well, what would you do with your family? Oh, well, how would I treat you then? Because, before I've just been talking about not the best treatment, now with my family, the best treatment. So I try not to push back too much on that question, but say, now listen, that's the way I would always treat you. It would be like family. So please don't think there's one for this and one for that. It's always the best.
Yeah, and I think that's always an important message to say. Like, this is exact. I would recommend this exact thing to my child or my spouse or my brother or sister.
Yes,
yeah.
Of course.
The other question that they get into is having different kinds of patients in terms of what they want to know about their disease or their prognosis or their diagnosis. I imagine some patients want to know everything, while other patients kind of like to remain in the dark and just trust you blindly.
Yeah, very true. That kind of comes up when, especially when you're seeing a patient consultation in the hospital, occasionally in a room in the office, and someone starts to move towards you or the family to move outside. And I always stop them and say, listen, I can't go outside and talk to you unless your mother, your brother, the patient says okay, because they're going to assume I'm saying something outside I can't say to you. And then interestingly, sometimes the patient say, oh, no, go ahead. I want you to do that. I don't want to know. Or, of course, more often, please stay and tell everything because I do want to know. So this conversation does go both ways sometimes. So
the question I have is how skilled do you need to be, and how do you navigate highly scientific pathways and checkpoints and mutations versus saying it in more layman's terms, and how do you educate a patient right there in the clinic?
Well, that's a great question. Early in my career, I'd be seeing a nurse, a doctor, healthcare provider, very sophisticated, I would assume, and I'd be speaking medical, and I could see very quickly they become uncomfortable. So no matter whom you are speaking with, the other side of the consultation desk, you want to be sure to speak English, simple, lay terms. That patients, no matter how sophisticated medically they are, with rare exceptions, really appreciate that.
Yeah, that's great advice. So that is coming up later. That is the conclusion of our 3-part series hosted by Dr. Ilana Yurkiewicz, who is the producer and voice behind Clinical Correlation. She is also the pen behind the Hard Questions column at MDedge Hematology, MDedge.com/hematology-oncology, and she's got a real knack for removing herself from the room and just observing what's going on. If you missed the first 2 installments of this, you can find links to those in the podcast notes, of course. It's time now to take a look at what's going on this week in hematology and oncology. We have conference coverage for you from San Francisco. The question is, what's the optimal time, the duration of maintenance therapy in multiple myeloma? And there are 2 schools of thought. Obviously, maintenance therapy has shown to almost double progression-free survival, overall survival in various trials. But do you treat until progression, or do you treat continuously? What's the school of thought here? So, Dr. Henry, did you get a chance to look at this article?
I did. I clicked this link, and the answer is easy. No one knows. The author goes through very nicely a couple of different trials where there were a couple of different lengths of maintenance, often lenalidomide, and up to progression, not up to progression. Certainly makes a difference to give it as opposed to not give it. But as you said, how long to give it is simply not known. The author nicely brings it on home with that conclusion, but spices it up with data along the way to show that it is better to give than not to give, and some differences in a year, 2 years, etc. So it's a very good question, and we're not quite sure of the answer.
One really interesting takeaway from this article that I hope that our audience will enjoy is one of the speakers in the panel suggested what the perfect trial to answer this question would be like, and I think that might be of some interest to the audience. So if you want to find that, you can find the link to This Week in Hematology-Oncology, as you always can, in the podcast notes. Well, Dr. Henry, I suggest you come down from your post-wedding high and join us back in the real world sometime soon. But thanks so much for coming on Blood and Cancer.
You're very welcome. Great job as always, Nick, and we look forward to hearing this interview.
All right, coming up next, the conclusion to our three-part series with Dr. Ilana Yurkiewicz.
Welcome to part 3 of this special edition of Blood and Cancer. I'm Dr. Ilana Yurkiewicz. These conversations are difficult and important to understand, so I thank you for joining us again this week. If you missed part 1 of the conversation, you can find a link to that episode in the show notes. If you have any ideas or comments on the conversations we have in these episodes, we'd love to hear your thoughts. You can email us at podcasts@mdedge.com. We may just include your thoughts in a future episode. And if you're looking for more content like this, you can check out my column Hard Questions at MDedge Hematology-Oncology. Thanks again for joining. And now, Dr. Emily Bryer and Dr. Ronak Mistry. So I'd like to move on to the third case. And the theme of this one is the patient and family ask, what would you do if this was your family member? So the case is, you are the fellow meeting a new clinic patient presenting for a second opinion. 2 years ago, she was diagnosed with a renal cell carcinoma and underwent a nephrectomy, but unfortunately the cancer came back soon after and was found to be metastatic. The patient was started on chemotherapy and then immunotherapy, but it progressed, and most recently, her course was complicated by fevers and an intra-abdominal abscess that could not be drained. She continues to have fevers even with antibiotics. She discussed more chemotherapy with her local oncologist, who noted that if the abscess is the cause of her fevers, additional chemo would worsen her immune system and could worsen the infection and lead to death within weeks or sooner. At the same time, this is the only chance they have to fight the cancer. She tells you she cannot decide what to do, and she asks you, what would you do if this were your family member? Have you ever experienced a question like this?
I don't know that I actually have ever experienced a question just like that. Ronak, have you?
Not in this particular context. I've received this question oftentimes. I've seen it most in the ICU when we have critically ill patients, many of whom have a very tenuous status. And this conversation comes up when we're having goals of care discussions about, whether the patient would want life support, whether they would want resuscitation, then mechanical ventilation, etc. Actually, not too long ago, I unfortunately had a very young patient that had a poor outcome and came into the hospital with hypoxic and rather anoxic brain injury. And his family had his mom said this exact thing to me. If he were your family member, what would you want us to do? It is incredibly difficult. I think in that particular situation, what I learned is the most important thing that I found for this family was for me to be very straightforward and say, how honest do you want me to be? And that worked incredibly. And, unfortunately the patient had a poor outcome in the end, but I can't even tell you how grateful this family was that I I said that one little thing, because they told me they would want me to be as honest as possible. And not that I would ever withhold information, but I think it changes the way that you deliver the information. And they wanted me to be very straightforward, and they were just so appreciative in the very end. And I think that is, the best lesson that I could ever take away from the experience that I had.
What did you tell them?
In this case, I told them that I expected this to be a very poor outcome. I didn't expect the patient to live without the aid of pressors and mechanical ventilation. And they took it, very hard, and they were very upset about that. But after I gave them some space and I let them think about it, and I checked in on them, they realized, after seeing everything that we were doing, that I wasn't giving up on their son. I wasn't telling them that I was going to do all that I could to try to reverse this. But they understood where I was coming from. And again, it kind of just gave them, in the best case scenario, they were hoping for something to turn around, but they were mentally preparing themselves for the worst case scenario. And I think that was really, really important to this family.
Yeah, I think that's a really powerful approach that you took. How honest do you want me to be? I really love that approach, because I think, the first thing you were doing, like we were discussing in one of the previous cases, was really you were addressing the emotion behind the question. Something palliative care teaches too is look for the question behind the question. What are they really asking? And I think by someone asking you, what would you do if this was your family member? It's really a trust question. And they're asking, can I trust you to take me seriously as someone you care about, as someone you would care about and make decisions for, as well as your own family member? And by answering, how honest do you want me to be? I think you're first addressing that. You're validating that. You're acknowledging that you're on their side. You're not going to abandon them. And you're establishing trust. You're establishing that you take them seriously and will give them the best possible information that's in your power. So I think that's a really fantastic approach. And, getting into then, we talk about the emotion, validating the emotion, and then the actual content. I mean, what if they say, I want you to be as honest as possible. If this was your mom, would you pull the plug or not? That makes it, a very, very difficult conversation. And how would you answer something like that?
I, of course, would have a hard time answering that. I know for sure, especially because when you now insert this being your own family member, you add that whole emotional component in your own mind. That being said, I think that this really does all cycle back to this whole theme of, I think, everything that we've been talking about tonight is really trying to understand what is the ultimate goal here. And I know that for my family and for my mom, the goal would always be quality of life. And so, if that's the case for this family, then, I might say, I don't know if I would ever use the term pull the plug for sure. But I would probably say that, maybe we should realign what our focus is here and try to find ways to ensure that she enjoys the time that she has, rather than, because in that case, it doesn't sound like you're withdrawing care or withholding care. Instead, you are opening up the discussion to other options that may not be medications per se, but other things that help improve the family and the patient's quality of life.
Yes, I completely agree. What you're getting at is the theme that we've been talking about, which is understanding the values of the person. And it's hard to answer that question if you don't know the values of the person, because the values of your mom or dad can be completely different from the values of this person or this person's family member. And so first I think another theme that I'm bringing up here is often just being really explicit, and breaking the fourth wall and saying that. And I've said things like, well, I know my family members and I know what their values are because we've discussed this before. And I don't know what your values are. Can you tell me what's important to you? So being explicit about the differences and what you're trying to tease out from the person. And Emily, I think it's really interesting that I guess I find this, I was bringing up really common scenarios that I get in fellowship. And I think it's interesting that you haven't gotten this explicitly just yet. Perhaps it's something that comes up actually more in the outpatient setting, and in residency, you guys probably have more experience in the inpatient setting. But this is this comes up a lot when someone's coming to you seeking a second opinion. They want to go to Stanford or University of Pennsylvania because they're these big name hospitals, and they think you have all the answers, and they're there to get a second opinion, and they want to know if they can trust you to give them as good care as you would give your own family member. So I've actually gotten this question many, many times, and I imagine you guys will as well, more in the clinic setting. So I'd like to move on to one more case. And this one also revolves around family dynamics. And this is the theme of this situation is where the family asks you not to tell the patient that they have cancer. So the case is, you have a new patient in clinic who was recently discharged from the hospital for a GI bleed and was unfortunately found to have metastatic stomach cancer. He is recovering well from his endoscopy and biopsy, and he is here today with his wife and 2 children to discuss the results and next steps. Outside the room, his daughter comes up to you and says that the inpatient hospital has told them it was metastatic cancer. She asks you to please not tell her dad, as it would destroy his morale. Is this a situation that you guys have experienced before in residency?
I have not experienced it with a cancer diagnosis, but I have with kind of HIV diagnoses and other diagnoses. But I think, the responsibility of the treating physician is to the patient, and they should, involve the family as much as they can. But I think it's the responsibility of the physician to speak with the patient about their health.
I agree. I think that at the end of the day, like Emily said, I need to inform the patient. I need to let him or her know what the situation is here. But again, just using this as an opportunity to speak with this family member and kind of dive a little deeper into what their apprehensions are about this diagnosis is really, really important. And then at the end of this discussion, explain to them that, while you understand where they're coming from, and again, it's coming out of a good place, you are treating the patient, and it's important to him or her. It's important to you to tell him or her about this new diagnosis.
Right, that's exactly right. So, I think you're both hitting on the point that the patient's autonomy comes first, and your obligation as the cancer physician is to the patients primarily. Of course, it's to the family as well, but it's up to the patient to make that decision. And so what you have to do in these situations, what you have to navigate is telling the family members that you will have to ask the patient directly what their preferences are. And sometimes the patient will say, that's fine, just defer everything to my kids. I don't need to know the details, and that's fine by me. And other times it might surprise the family when the patient says, no, tell me absolutely everything. I actually want to know all the details. And if the second situation is the case, it is your obligation to then explain to the family and to the patient that you have to do what the patient wishes, which is to tell him or her everything that they want to know. And I think the second point that you guys are hitting on as well is, it's while your obligation is to the patient, it's important to recognize what the family dynamics are and try to tease those apart a bit, and to commend the family because their instincts are they're trying to protect the patient. They're looking out for what they think is their best interest. And this is another situation where I might explicitly say that I applaud you for looking out for their best interest and not trying to take away hope in a really difficult situation, but that it is ultimately his decision. Any thoughts on how you might phrase that? And what I mean is, how would you phrase that to the patient in front of the family, that you're trying to understand what the patient wants without offending the family, without rejecting what their wishes are.
And I've seen this conversation being had. I should mention that our palliative care team at the hospital is pretty great, and I've had the opportunity to sit in with them in a lot of family meetings. Again, not necessarily about cancer diagnoses, but any sort of terminal diagnosis. And one of the things that they've done really well, which I've tried to emulate in my own practice, is trying to figure out where the patient's at, and explain to them, in this case, I understand that you were recently in the hospital, and we did some tests. What do you know so far? And kind of see what their understanding is. Something else that they often do in these situations is also then go on and say, what are your concerns and what are your fears, in regards to whatever just happened. And I think that again lends itself to indirectly figuring out where the patient's at emotionally, mentally, and goal-wise. And then you kind of, I think thereafter, I think you have to kind of lose the generic approach and kind of feel out the room. And that's where the conversation will be very much dictated by the emotions that you can feel from the family members, from the patient. And like Emily said, that's your opportunity to kind of figure out, how much the patient wants to know.
Yes, I think that's exactly right. I mean, it's incredibly important first, before you start bombarding people with information, is to find out what they know. And I can tell you, I've been in many situations now where I've been surprised by what they answer, where you think someone has a really nuanced understanding of their disease, and then they'll say something like, oh, I have a tumor in my liver, and then it's not in their liver at all. It's actually completely a different type of cancer somewhere else. Mm-hmm. Or that they don't even know they have cancer. They just say, oh, I'm here because I heard I was sick with something. And before you start giving information, taking a step backwards is figuring out where the patient is and where the family is, so you can meet them there and then go forward. And I think the other thing you said, which I think is also fantastic, is sitting in on or inviting palliative care to these conversations that you're going to have in fellowship, and always remembering that they are just such a fantastic resource for difficult conversations, not just at the very end of life, which is unfortunately sometimes when people remember to refer, but early on, early and often, that they can just be a fantastic resource in helping you and helping the patient navigate these situations. So I want to thank you both for a really fantastic discussion. I think you are more than prepared for fellowship, and I look forward to seeing what you guys do and learn over the next few years. Any other thoughts that we didn't talk about?
No, thank you so much for having us.
Yeah, and thanks for facilitating this. This is, like you said, extremely important. And I'm really glad that we had this chance to flesh all this out. I know Emily and I, like we saw in this, we experience these things quite often, but it's kind of just something that you learn and kind of get comfortable doing, and I think that we are, I would say, despite the fact that we're still in residency, it's almost, this gave me a chance to reflect and see how much of this we've already experienced at our program. And so I'm really thankful for that.
And also still how much I have to learn about it. It's complicated. They're not simple discussions. They're quite heavy, and it's so much involves responding and reacting to the patient and the family that you have in front of you. It's not a cookie cutter conversation that you can have by any means.
Yes, exactly. You can think of good phrases, but every patient is different. Every family member is different. Every family meeting you have is going to be different from the last. So thank you guys so much again for being here. And I look forward to chatting with you again, hopefully soon.
Wonderful.
Thank you so much.
Thank you guys. Take care.
Bye.